Okay, today's topic is neurosurgery. First way, the intracranial dynamics, nothing much is there. Just they are telling about the Monro-Killian doctrine, which we know there is a compensation mechanism. Okay, the CSF, the cerebral blood flow, brain parenchyma, everything is contained in a space. So if any one thing is, and it's a constant. Okay, if any one thing increases or decreases, subsequently the other thing compensates. Second page, coming to this second paragraph, the second principle is that the spinal fluid is produced at a constant rate of 15 to 20 ml per hour by the choroid plexus of the ventricle. It is essential to understand that the production of CSF is little affected by the increased ICP. Thus, CSF production continues unabated even to lethal elevation of the ICP. Next, the only exception to the almost constant CSF production are the excess production associated with the rare choroid plexus papilloma and the occasional decreased CSF production seen with the ventriculitis. Choroid plexus papilloma increased CSF production, ventriculitis decreased production, rate of production is 15 to 20 ml per hour. So production is little affected by increased ICP. So production continues even till lethal elevation of ICP. So third principle is the CBF normally varies over a wide range, that is 30 to 100 ml per 100 gram of brain tissue per minute, depending upon the metabolic demand from the neuronal activity within the particular brain area. So the blood flow to any brain area is generally abundant, exceeding demand by a wide margin. So the oxygen extraction ratio is often low. So they can ask a true or false statement. Oxygen extraction ratio are often low. So cerebral blood flow generally maintains what is needed despite wide variation in the systemic blood pressure by a phenomenon known as the autoregulations. So in this diagram, you can see two things. Okay, so in traumatic brain injury, the curve is steeper with larger cerebral blood flow changes occurring with small pressure changes. That is, the auto-regulation mechanism is hampered. And with relation to the CO2, PCO2 levels, if there is a hypercapnia, then there is a cerebral blood flow will increase. So hypocapnia, cerebral blood flow will decrease. So that's why we employ this hyperventilation. If you hyperventilate, there will be decreased cerebral blood flow. So you can maintain the ICP, intracranial pressure. Okay, but it is detrimental as well. So we have to monitor it properly, which we'll see later. So the first, if the tissue demand exceeds the auto-regulation, or if the cerebral blood flow declines for pathological reasons, the first defense is the oxygen extraction will increase. That is arteriovenous oxygen difference. The tissue begins to experience dysfunctions at levels below 0.25 ml per gram of the brain tissue per minute, with levels between 0.15 to 0.2 ischemia, reversible ischemia will happen. So when will infarction happen? When the level is between the 0.1 to 0.15. These three are MCQ. Okay. When dysfunction happens as 0.2, below 0.25 ml per gram of brain tissue per minute, and infarction when it is 0.10 to 0.15. So the metabolic consumption of oxygen in the brain is decreased after traumatic brain injury to levels between 0.6 to 1.2 micromole per milligram per minute. So complete loss of blood flow to any brain area results in infarction within few minutes. Swelling of the infarcted tissue takes days to peak and weeks to resolve. Fourth principle is they are telling about the pressure changes. So cerebral perfusion pressure is equal to mean arterial pressure minus the intracranial pressure. When the capacity for the autoregulation is exceeded or damaged so that it can no longer play a role, cerebral blood flow is linked directly to the CPP. So when autoregulation mechanism fails, cerebral blood flow is directly related to the cerebral perfusion pressure. So that's why we need to reduce the cerebral blood flow by inducing hypocapnia by using hyperventilation. So CPP, cerebral perfusion pressure, we have to maintain in the range of 60 to 70 mmHg, and intracranial pressure below 22 millimeters of mercury if possible. Routinely using pressors and volume expansion to maintain cerebral perfusion pressure more than 70 is not supported on the basis of systemic complications. So pressor support and volume overloading and subsequently increasing the CPP is not recommended. So before this, the previous page, there is a tabular column, intracranial excess volume syndromes and its treatment. So first component, brain tissue edema. It can be cytotoxic, vasogenic, perineoplastic, inflammatory. So treatment is, you can give diuretics, that is mannitol, furosemide, or hypertonic saline, and steroids only for this perineoplastic and inflammatory vasogenic edema. Second is vascular component, elevated PCO2. In this, we have to note for vascular cause, we can increase the ventilation and can give diuretics, but mannitol is avoided. That is the MCQ here. Okay, for vascular excess volume syndrome with elevated PCO2, avoid mannitol. Barbiturates can be given, then clear the venous obstruction, then elevate the head end of the bed. Then CSF. CSF, if it is excess, we have to do a ventricular external drainage, okay, or lumbar drainage if no risk of herniation. With flocculation or with some type of obstructive hydrocephalus, endoscopic fenestration or third ventriculostomy may be possible. Then acetazolamide and steroids may temporarily decrease the CSF production. Acetazolamide, we know, steroids also. Next is mass lesion. Mass lesion can be of any, you have to note about the radiation necrosis also. It also causes mass lesion. So treatment is aspiration, often with stereotactic guidance, less commonly by the surgical decompression. Okay. So significant MCQ is a vascular cause, you have to know. Diuretic can be used, ventilation can be increased, and mannitol should be avoided. CSF, we know, mass lesion, we have to remove, fenestrate or aspirate the lesion. And sometimes a decompressive craniotomy. So right side, we have to see. Then the cranial cavity contains several knife-like projections of folded dura, that is the fox and the tentorium, which divide the cranial cavity into right and left supratentorial compartment and an infratentorial compartment, that is posterior fossa. Then the sphenoid wing. Sphenoid wing is a prominent, mostly bony ridge that separates the anterior fossa containing the frontal lobe from middle fossa containing the temporal lobe. So which separates the frontal lobe and temporal lobe is sphenoid wing. Then the narrow opening incisura edged by the tentorium surrounds the midbrain and is the only passage between the supratentorial and infratentorial. So connection between supra and infratentorial is by the incisura. Apart from the small openings for the nerves and arteries, the foramen magnum is the only sizable opening in the cranial cavity. So this flow chart, it shows the frame. Can you change post? The internet problem.
Hello, yogesh.
Yes, sir.
கேக்கல இப்போ பிரேக் விட்டியா? நான் இப்போ நடுவுல கால் வந்துச்சு உனக்கு.
இல்ல சார், இன்டர்நெட் பிரேக் ஆயிடுச்சு.
அப்படியா? ஓகே.
ராஸ்ட்ரோகாடல் டிகேல இருந்தானே கேக்கல.
இல்ல the condition illustrates the expanding mass lesion la irukla adula and or points கொடுத்திருக்காங்க பாரு.
ஓ அதுல இருந்தே கேக்குது. conditions illustrating syndromes
இல்ல இதுதான் அந்த இதுதான் rostrocaudal decay தான்.
rostrocaudal decay தான். நான் ஹோஸ்ட் மத்தி விட மாட்டேங்கிறேன். பிரேம் சார் கால் பண்ணி சொல்லுங்க சார். ஏன் ரெக்கார்ட்ல போட்டு முடிப்போம். சார் கால் பண்றீங்களா?
யோகேஷ் இந்த ஹைப்பர் வென்டிலேஷன் அந்த பாயிண்ட் சொல்லு.
ஹைப்பர் வென்டிலேட் பண்ணா என்ன ஆகும்? ஹைப்போகேப்னியா வந்துருமா? ஹைப்போகேப்னியா வந்து என்ன ஆகும்? செரிப்ரல் பிளட் ஃப்ளோ கம்மியாகுமா?
சோ கார்பன் டை ஆக்சைடு வாஷ் அவுட் ஆகுறனால ஹைப்போகேப்னியா.
ஆமா, ஹைப்போகேப்னியா வந்துச்சுன்னா உனக்கு செரிப்ரல் பிளட் ஃப்ளோ வந்து கம்மியாகுது. ஓகே
ஓகே.
செரிப்ரல் பிளட் ஃப்ளோ கம்மியாகிறதுனால நம்ம ஐசிபியை வந்து மெயின்டைன் பண்ண முடியும். அதனாலதான் இன்க்ரீஸ்ட் ஐசிபில ட்ரீட்மெண்ட்டா ஹைப்பர் வென்டிலேஷன் யூஸ் பண்ணுவாங்க.
சோ ஹைப்போகேப்னியா வரதுனால நிறைய பிளட் அதுக்கு ரெஸ்பான்ஸ் நிறைய
கம்மி பிளட் போகும்.
கம்மி பிளட் போகுமா?
ஆமா.
ஓகே ஓகே ஓகே.
அதான் அந்த கிராஃப்ல கொடுத்திருக்காங்க.
வாய்ஸ் வரல. ஹலோ.
Okay, the sequence of events in rostrocaudal decay. First, there will be a focal distortion, then effacement of the gyri and sulci, then compression of the lateral ventricle, then midline shift, then subfalcine herniation, then temporal lobe tentorial herniation, then third nerve compression, then obliteration of basal cistern, then midbrain compression. And when midbrain infarction happens, it will be associated with durate hemorrhages and all. So both pupils will dilate with irreversible damage to the midbrain. Then further brainstem compression. Next, loss of brainstem reflex, that is progression from the flexor posturing to extensor posturing. Then vestibulo-ocular and oculocephalic reflexes. Then corneal reflexes. Then medullary compression syndrome, that is respiratory reflex, vasomotor reflex, Cushing's reflex with elevation of systolic blood pressure, widening of the pulse pressure. Then there will be bradycardia, and finally foramen magnum herniation. Important things to remember is, first one is lateral ventricle compression, then midline shift, then subfalcian herniation, then temporal lobe herniation, then third nerve compression, then midbrain compression, then brainstem, and finally medulla compression. So at stages beyond temporal herniation, it is unusual for focal mass effects not to be accompanied by an overall increase in the ICP. Okay. Young patients with the so-called tight brain can develop raised ICP even with relatively small volume of mass. Okay. On the other hand, patients with advanced cerebral atrophy can tolerate large frontal intracerebral hematoma or chronic STH with compression of the lateral ventricle and midline shift while maintaining a tolerable ICP and surprising degree of near normal neurological function. So young patients will be affected with the mass effect more than the old age patients because they will have cerebral atrophy, so there will be space for accommodation. Next, coming to the cerebrovascular disorders, first we see the box. Congenital, acquired, idiopathic, three causes are there. Congenital, we know AV malformation, cavernous malformation, telangiectasia, angioma, and all. Acquired malformation is divided into traumatic, degenerative, and infectious. So in traumatic, note type 1 carotid cavernous fistula. Okay, is a traumatic acquired cause of cerebrovascular disease, whereas type 2 carotid cavernous fistula is idiopathic. Okay, that one point you note. Then degenerative causes we know infectious mycotic aneurysm, that is bacterial infection, embolic kind of thing. Then idiopathic moya disease and dural AV malformations and all. So first coming to AV malformation, abnormal collection of blood vessels wherein arterial blood flows directly into the draining veins without the normal interposed capillary beds. So there is absence of capillary bed. So arterial blood goes directly to the veins. They enlarge with age, recruiting new vascular supply, and often progress from low flow lesions to high flow lesions. Then they present with the steel phenomena, that is ischemia of the brain parenchyma around the lesion due to vascular, that is shunting of blood will be there. So they have a prevalence of 15 and typically manifested before the age of 40 years. The risk of hemorrhage is 4%. This is important. AV malformation, risk of hemorrhage is 4% per year. Once they bleed, they may be more prone to hemorrhage. They are typically composed of one or more feeding arteries. So the subsequent bleeding rates will be higher, and there will be one or more feeding arteries, and there will be abnormal vessels and draining veins. So treatment option, what we have to do is we can craniotomy with cervical decompression, then embolization, then stereotatic radiosurgery. Commonly, more than one modality is used. Okay, surgery with the embolization or SRS, we combine any two modalities. So SRS is usually reserved for compact lesions less than 2.5 centimeter in diameter. It can take up to 3 years for the irradiation. Okay, treatment duration is 3 years. SRS is for compact lesion less than 2.5 centimeter in diameter. Next, cavernous malformation. So it is a well circumferenced benign vascular lesion. Contains irregular thin-walled sinusoidal vascular channels located within the brain, but lacking the intervening neural parenchyma, large feeding arteries, or large draining veins. So difference between AV malformation and cavernous is cavernous won't have this feeding artery or large draining veins and intervening normal neural parenchyma. So these are low pressure lesions, but AV malformation will progress. Initially, it will be low flow, then it will be high flow. Here it is low flow lesion. Hemorrhage is typically not catastrophic unless it is in the eloquent areas of the brain. So MRI is the imaging modality of choice. So we'll see a characteristic dark hemosiderin ring. So treatment for symptomatic lesions include seizure control and the excision. Radiosurgery, it decreases the rate of bleeding in lesions not amenable to surgical resection. Next, capillary telangiectasia. These are vascular channels with extremely thin walls similar to those of dilated capillaries. They are grouped in small cut clusters, generally with a prominent intervening brain tissue. They are often clinically silent and generally do not appear on the imaging studies. So this is MCQ. So capillary telangiectasia are silent and they do not appear on the imaging studies. They are not evident on the conventional catheter angiography unless they are large, and then only in the capillary venous phase. Okay, only in capillary venous phase it might be seen, and only if they are large it will be seen. So it differs from AVM by the fact that flow through the lesion is not fast enough. So these lesions are typically not treated surgically. So capillary telangiectasia, 3 important points. Okay, they are dilated capillaries, often silent, and doesn't appear in the imaging study. Then no treatment needed. Next, developmental venous anomaly, that is venous angioma. It consists of abnormally configured venous drainage system converging on a single enlarged venous outflow channel. Typical appearance is hydral with radially converging veins. The characteristic feature of this lesion appears to be that the abnormal venous bed is poorly collateralized. So this is the key point here. There will be poor collaterals in the venous angioma and hydra appearance. They may or may not be fully adequate to the needs of the brain tissue supplied. Slowly evolving degenerative changes in the brain tissue supplied can occur as a result, but unfortunately, this is not helped by any known intervention. So interventions will not help in treating the degenerative changes in the brain. So however inadequate, the venous anomaly presents the only venous drainage available to that area, then removal of the venous anomaly is not recommended. Okay, this is also MCQ. Venous angioma also, excision is not a treatment. If we excise, that will be the only supplying vein. So next, this tabular column, they have given Spetzler-Martin grading. This is for AV malformation. Okay, the parameters are size, eloquence of the adjacent brain, and pattern of venous drainage. Score is given according to it. They haven't mentioned what is the significance of the scoring. They have just to know the severity maybe. Okay, so size less than 3, 3 to 6, more than 6, 1, 2, 3 points. Then if it is an eloquent area means sensory motor, language, visual, thalamus, hypothalamus, all those important areas for function. Then pattern of venous drainage, if it is superficial only, score is 0. Remember, not 1. Okay, and for deep it is 1. Spetzler-Martin grading for AV malformation. So next is traumatic fistula. So traumatic fistula, the internal carotid artery passes through the cavernous sinus, which communicates with the superior ophthalmic vein, petrosal sinus, and sphenoparietal sinus. Okay, so communication of ICA, superior ophthalmic, petrosal sinus, sphenoparietal sinus. The vertebral artery passes through venous plexus, the occipital epidural space.
Yogesh, voice clear alla. Yogesh, voice clear alla.
Break the
clear கேக்கல, விட்டு விட்டு கேக்குது. ஹலோ, கிளியரா கேக்கலடா.
ஹலோ,
சுகந்த் எங்க போனா? லீவா?
ஹலோ, ஓகே வாய்ஸ்?
இப்போ ஓகே.
இது மறுபடியும் ஹோஸ்ட் போயிடுச்சு.
நீ என்ன நீயே லாகின் பண்ண வேண்டியது பிரேம் அக்கௌண்ட்ல யோகேஷ்?
ஆக்சுவலா நான் சென்னையில இருக்கேன். நான் முத்துக்குமரன் ஹாஸ்டல்ல இருக்கேன். வைஃபை இல்ல என்கிட்ட.
ஓ
சென்னை வண்டியாடா?
மொபைல் நெட்டை வச்சு இது பண்ணிருக்கேன்.
ஓகே ஓகே ஓகே. நீ வீட்டுக்கு வரதுனா வாடா யோகேஷ்.
வரேன்டா. நான் வந்ததே நேற்று நைட்டு தான் வந்தேன். அப்புறம்
நீ நேரா வீட்டுக்கே
கிளாஸ் எடுக்கணும்னு இதை உட்காந்து வாசிச்சுட்டு இருந்தேன்.
அதான் இங்க தம்பி ரூம் சும்மா தான் இருக்கு. நீ வீட்டுக்கே நேற்று நைட் வந்திருக்கலாம்.
நீங்க ரூம் போட்டிருக்கேன் ஹோட்டல்ல.
அவன் எங்க இருக்கான் சார்? நான் இங்க யூஜி காலேஜ்ல இருக்கான் ஹாஸ்டல்ல.
ஓஹோ.
ஹலோ யோகேஷ் கேக்குதா? ஹலோ, நெட் கிடைக்கல போல சார்.
இங்க ஸ்டான்லி இல்லையா?
என்ன சார்?
ஸ்டான்லியா?
இல்ல சார், எங்க யூஜி காலேஜ் முத்துக்குமரன்.
ஓகே 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 ஓகே.
இங்க இந்த இது பக்கத்துல, இந்த பூந்தமல்லி பக்கத்துல.
ஓகே ஓகே. அங்க யார் இருக்கா?
எங்க சார்?
இல்ல அங்க தான் படிச்சான் அவன். அங்க
நாங்க யூஜி அங்க தான் சார் படிச்சோம். நானும் யோகேஷ் அங்க பேட்ச்மேட்.
ஓகே 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 ஓகே. அவங்க வைஃப்
ஏதோ எக்ஸாம் போல சார். ஏதோ இங்க ஓஎம்ஆர் இசிஆர் சைடு தான் சொன்னான். ஏதோ எக்ஸாம் போல.
டிஎன்பியா?
தெரியல சார். ஏதோ எக்ஸாம் சொன்னான்.
ஓகே ஓகே.